Hello, everyone. Welcome to Know Neuropsychology. We'll get started in just a minute. Right. All right, we can go ahead and get started. So, hello, everyone. My name is Iman Quadra Reddick. We are pleased that you could all join us for this week's lecture in Volume 10 of our Know Neuropsychology didactic series that brings you lectures from experts in the field covering different topics each week. This series was created by trainees and early career neuropsychologists, including standing members of the Know Neuropsychology Board, as well as members of the Know Neuropsychology Committee. Before we start our lecture, one of the main goals of Know Neuropsychology is to provide free, high-quality didactic content to our audience. Every Know Neuropsychology and Know Neuroanatomy lecture is available on our YouTube channel. Be sure to check it out, subscribe, and like our lectures to get access to our new content. New to Know Neuropsychology is our collaboration with Apson to bring you learning and discussion questions that are provided with specific lectures content. You can access these on our website and through Apson. Are the disclaimers for the series? This training is not meant to replace formal education in neuropsychology, and the views of the speakers are their own. Questions can be submitted via the Q&A box on the lower left of your screen, and a recording of today's lecture will be provided on our website and YouTube channel later this week. Now it is my pleasure to introduce Dr. Lee Isaac for today's lecture titled Cognitive Decline in Neurosurgical Interventions, Considerations in the Older Adult Population. Dr. Lee Isaac is a geriatric neuropsychologist at the University of Arkansas for Medical Sciences. He is the Director of Neuropsychological Services, co-director of the Behavioral Neurology Clinic, and Associate Director of the Psychiatry Residential Academic Track. Dr. Isaac also supervises neuropsychology interns and fellows through the University of Arkansas for Medical Sciences APSIN training program. Current scholarly interests and projects include characterizing amyloid-related imaging abnormalities and its impact on white matter networks, the effect of loneliness on white matter integrity and cognition in older adults, and diagnostic specificity in neurodegenerative conditions. Well, Dr. Isaac, we are so excited to hear from you, so I'll turn it over and you can start sharing your slides.
All right, thank you for the introduction. I'll just put this. So you should all be seeing my slides now. Again, I appreciate the introduction. As she said, my name is Lee Isaac. I'm a geriatric neuropsychologist here at the University of Arkansas for Medical Science. My roles are primarily clinical, administrative, some engagement in training, research. For the presentation today, I'm going to talk about post-operative cognitive decline in neurosurgical interventions, particularly emphasizing it for a geriatric population. So here's sort of a basic agenda for today. I'm going to talk about geriatric neurosurgery in general. This is sort of a growing subspecialty that will be increasing in need over the coming years. We'll talk about post-operative cognitive decline. At first, we'll kind of discuss the concept broadly, then talk about some of the known mechanisms and risk factors for POCD. A lot of that data is largely based on what we know from non-neurosurgical interventions, but many of these concepts are applicable to a neurosurgical population, just with some caveats and some added complexity. Then we'll talk about some of the data we have for three types of neurosurgical populations that we as neuropsychologists more commonly interact with. So DBS, epilepsy, and neuro-oncology. Just discussing sometimes the more limited data that we do have about cognitive effects in older adults, but also including things like complication rates, outcomes. And then finally, I'll just kind of briefly finish us off talking about some clinical recommendations about things we need to be focused on moving forward, and things further investigation that we really need to do as a field just to fill out some of what we do have available. So, as I am sure you are all aware, there is a growing geriatric population with the United States and in the world in general. This is really owing to a number of different reasons, but one of the large contributors is increasing life expectancy. Older adults over the age of 65 are one of the most rapidly growing demographics within the US, and the often talked about sort of baby boomer generation. By 2030, we'll have all reached that marker of 65 years of age or older. This 65 and older demographic is expected to balloon to over 72 million by 2030. However, in addition to that sort of larger bucket of older adult sort of contingency, we also have relatively rapidly growing subpopulations demonstrating market growth. So those are populations like the oldest old. So those are individuals over the age of 85, which is one of the fastest growing demographics in the United States, even though it's, relatively small. I think from the 2010 to the 2020 census, individuals over the age of 95 actually grew almost 40%. So again, while these are kind of small numbers when we're considering sort of the overall population, there is sort of a large growth, and that is only going to continue to grow. The population over the age of 65 is expected to double over the next couple of decades, and triple for those over the age of 85 in that same period. This is sort of particularly notable because this is going to create unique demands, stresses on our healthcare, force on our healthcare systems. And so we're going to have a growing need to continue to address the geriatric population and sort of, again, some of the unique considerations that go along with them. And so with this sort of like growing population, these increased demands, we are going to see some additional focus, some additional subspecialties directed toward the geriatric population. Geriatric neurosurgery is one of those subspecialties that has gained increased interest as these sort of demographics have shifted. This isn't necessarily a surprising outcome if you were to compare this to more sort of well-established subspecialties like pediatric neurosurgery. There are definite benefits to having increased emphasis and expertise with a more narrow band sort of population. When we talk about pediatrics, I'm not a pediatrics person, but when people talk about pediatrics, they often talk about how kids cannot be seen just as smaller adults. I think that really is mirrored in our older adult population. They have unique challenges, unique considerations that warrant expertise. And so, I think we're remiss to simply view this population as adults who have advanced in age. There are sort of unique changes that happen during later life, particularly as we're having patients live longer and longer, and having greater life expectancy. I think we need, as a healthcare system, need to sort of bend and shift and be flexible, and really put sort of continued increased focus on meeting these needs. Geriatric neurosurgery in particular is of growing need because a lot of the conditions that require neurosurgery disproportionately affect older adults. So we think about conditions such as stroke, TBI, NPH, epilepsy, movement disorders, brain tumors, etc. There really is a high prevalence rate in later life. And many of these require or can benefit from neurosurgical intervention. Conversely, neurosurgery also has higher treatment-related risks, in some cases, poor expected outcomes, with most of these procedures having more extensive and intensive recovery processes, greater stresses on overall physical health. And those demands are particularly notable as older adults are often more likely to be physically frail, have a greater number of comorbidities, and be more likely to have pre-existing cognitive and neurologic disorders. So this creates somewhat of a paradoxical situation when we have this group of patients that experience a higher rate of these conditions, but who may also be at higher risk to possible negative treatment outcomes, negative treatment complications. This can obviously vary by individual, depending on that individual, the type of stressor, and their sort of starting ability. If you look over this graph on the right, this is sort of capturing that and capturing some of the spectrum on which we will see different older adults and how their response to different stressors can vary and how the recovery trajectory can vary. So based on their sort of level of initial physiological reserve, and physiological reserve is essentially a correlate to what we think of when we think of cognitive reserve. Based on their level of physiological reserve at baseline, dependent on the type of stressor that they experience, that will then sort of shift and change their recovery trajectory. Importantly, in considering this is being able to try to keep patients as independent as possible. This is important, obviously, from a patient perspective, but also from a healthcare perspective. We have limited resources, and we have a growing geriatric population. And so as that population continues to grow, we need to make sure that our systems are still doing everything that we can to try to really enhance independence, enhance autonomy, and allow people to continue to care for themselves for as long as possible. Unfortunately, with continued demand, strains on the system, what that means is that there will be care gaps, and individuals who suffer the greatest from care gaps are often those who need that care the most and need those associated resources the most. And so, in being able to better address these as a healthcare system, a healthcare force overall, we hopefully will allow fewer of those people to kind of slip through the cracks that most need us and most need our help. And so again, trying to prevent these outcomes as much as possible really is of sort of paramount importance. Fortunately, again, this is sort of a growing area of research, looking at sort of viability of neurosurgical procedures in older adults. These and there've been several studies sort of looking at if patients are sort of viable, if it's safe for them to do it. For example, two here that are looking at octogenarians, which are just individuals over the age of 80, and comparing them to younger age match controls. And so in this 2018 study, they were looking at those over the age of 80 as compared to those in the age range 60 to 71. And we're looking at neurosurgical interventions, and this was for about 260, 270 patients. At follow-up, the over 80 group showed significant recovery after procedures, while they were a little bit more prone to certain post-operative complications. Those complications were not of the class that were most severe. and did not require an extensive sort of therapies afterward. So, again, while there was a slightly higher complication rate in comparison to the younger group, we were not seeing higher rates of severe morbidity or mortality. Consistent with these findings, this 2022 study looked at 66 octogenarians, again, undergoing complex cranial procedures. And there was a relatively low complication rate, only about 10%, with no patient deaths. So, both these studies and others lead credence to sort of the notion of the value of geriatric neurosurgery, the benefits of continued research to better understand the interacting forces of age and risk factors to maximize outcomes. And that's something that I think I also want you all to hear throughout this is, this is an area that really needs research. We need to know more. We need to know more about this older population. You go back 20, 30 years, they just weren't doing surgery on patients who were 80, 90, weren't doing neurosurgery on those patients, or it's pretty rare. And so we really need more data. And I think this is really a hole that neuropsychology is very able to fill and help with. And so now I want to talk a little bit about post-operative cognitive decline, or POCD. So this is something that is more traditionally talked about in the context of non-neurosurgical interventions. However, these next couple slides are going to cover POCD because many of these concepts can be similarly applied to neurosurgical interventions. In neurosurgical intervention, we often focus on some of the more obvious direct causes of cognitive change. For example, if you see a patient and they undergo resective surgery, then it makes sense to focus on the resection as the cause of cognitive change. However, I think as we continue to better understand sort of geriatric neurosurgery and understand it from a more kind of holistic perspective, I think we need to consider some of these other contributory forces that can be just as important to cognitive functioning in sort of the long term. And so broadly, when we're talking about postoperative cognitive decline, it's defined as an onset of emergent cognitive impairment exceeding the expected recovery time from the acute effects of surgery and anesthesia. So kind of very simply, these are persistent deficits above and beyond what would be anticipated from the normal recovery process. This is a relatively broad concept that encompasses sort of a wide array of outcomes. And so there have been calls for greater standardization, more terminology. For example, I saw one paper that's calling for using terms like delayed neurocognitive recovery to signify the first 30 days, and then using terms that are sort of more comparable to our DSM classifications. So things like calling it post-operative mild or major neurocognitive disorder if we are seeing those persisting deficits past 30 days. I really am a fan of using that sort of terminology, which maps on well to our current schemas of cognitive disorders, cognitive severity. It makes it much more seamless for that to enter into our sort of clinical vernacular and be able to use those terms and use them sort of fluidly. Again, there's just an inherent logic to it that if you know about what that means, you can sort of easily apply that to this sort of like post-operative stage and makes that process more seamless. In regards to POCD overall, rates can vary pretty significantly based on type of surgery. POCD, again, this is often non-neurosurgical, and so they often will separate between cardiac and non-cardiac procedures. Cardiac procedures demonstrating a much higher rate of POCD, many studies showing rates above 50% at 3-month follow-up. For this, and sort of importantly, POCD is not just a change in cognitive ability. It has other sort of downstream effects. So POCD has been also found to be associated with subsequent declines in quality of life and functional abilities. And so these have real world consequences for the patients that are undergoing this and experiencing this sort of further decline in cognitive ability. It really has been found to sort of touch in all functional areas. So things like social activity, household management, attendance of appointments, financial management, shopping, transportation, again, can sort of run the whole gamut of these sort of functional IADLs, ADLs that do impact this sort of older adult population. And so importantly, as we'll discuss, age is a strong sort of independent risk factor for the development of post-operative cognitive decline. And so it's of particular concern when we're thinking about things from sort of a geriatric neurosurgical population. And so now I'm going to touch a little bit on some of the mechanisms that can lead to postoperative cognitive decline. Again, a lot of this has been done in neurosurgical populations, but can be mirrored into non-neurosurgical, but can be mirrored into neurosurgical. Neuroinflammation, even sort of across procedures, is thought to be one of the primary mechanisms of postoperative cognitive decline. Neuroinflammation in patients is likely probably a multifactorial process with some synergistic effects between anesthesia, surgery, and even sort of the preoperative inflammation state of a patient. So someone's pre-op sort of potential inflammatory environment can in and of itself then make them more likely to experience systemic and neuroinflammation. In addition to that, any foreign material that comes into contact with circulation can cause an inflammatory process. However, we've seen inflammatory responses for a multitude of surgical processes. So even any sort of like non-normative surgical stressor can sort of serve as a provoking factor for an inflammatory response. Neuroinflammation in itself can cause edema, cause subsequent rupture of astrocytes, degeneration of neurons. Furthermore, systemic and neuroinflammation can cause disruption to the blood-brain barrier and migration of things like inflammatory mediators actually into the brain parenchyma. These pro-inflammatory states then can stimulate microglial cells, which further cause sort of inflammation, sort of amplifying it with the endpoints for this whole sort of inflammatory cascade leading to synaptic dysfunction and eventually cellular death. So sort of in this process, inflammation sort of begets more inflammation and begins this cascade that ends up sort of resulting in further inflammation and can cause almost a cyclic ramp up in inflammatory processes. Neuroinflammation has been linked to nearly all neurologic conditions. And so, it likely serves as at least a partial link to both near-term and long-term changes in this population. Sort of an additional mechanism when thinking about sort of post-operative decline is any acute intraoperative or post-operative events that can cause significant cognitive change. These are luckily fairly rare dependent on type of neurosurgery, although they can still occur. And again, that base is dependent a little bit on type of neurosurgery that the patient is undergoing. Broadly, this encompasses things like infarcts, hemorrhages, edema, intraoperative hyper or hypotension, or seizures. Infarcts are often related to artery or vein occlusions, although in more rare cases it can be related to cerebral vasospasms, although this is often sort of a more delayed outcome. Seizures can be common in any surgeries that require craniotomies, with this happening in about 10 to 20% of those that are supratentorial. Cerebral edema, which you've kind of touched on briefly before, is also possible and can, again, be caused by this neuroinflammation. It typically occurs several hours up to 3 days after surgery. And the extent of edema is usually influenced by a number of factors, things like amount of direct sort of brain manipulation, duration and force of retraction, and sort of various other parameters that then influence the sort of subsequent swelling and edema. Um, Anesthetic agents can exacerbate cerebral edema and intracranial hypotension, and compromise of the sort of venous systems overall also causes or worsens edema. Finally, intracranial hemorrhage is one of the most dangerous complications of neurosurgery. Post-operative hemorrhage often commonly occurs within or near the operative bed, but it can actually also occur in more remote sites, sort of away from that sort of original operative bed. Major causes of post-operative hemorrhage include uncontrolled bleeding from inadequate hemostasis, difficult tumor um, resection, retraction, injury, regional changes in blood flow due to removal of a lesion. Actually sort of removing that lesion changes the overall almost like ecosystem of that region of the brain, and hypertensive surges that happen during recovery. Risk factors for some of these remote hemorrhages include things like brain atrophy, pre-op shunting, pre-op use of certain medications, and if an upright position is used during operation. And so all of these sort of more acute events can, as we would all expect, cause subsequent cognitive issues. And so then, the third sort of mechanism that's important to think about is, these are neurosurgical populations. And so what that means is that as a consequence of some of the treatments of some of the surgeries, there can likewise be declines and change in cognitive function. This can be secondary to the main surgical procedures, for example, in resective surgery. Loss of any neuronal tissue that is healthy and functional will result in possibility of declines in associative cognitive function. We work closely with our neurosurgery team here, and our epilepsy neurosurgeon that comes always gives us a talk every year in our didactics, and he talks about this sort of fine balance you have to walk between wanting to take enough tissue to get the treatment outcomes that you want, to get the seizure control that you want, and trying to also do that where you limit the potential cognitive effects. And as much as we continue to try to improve our accuracy with that, it still is not a precise science. And so as a proxy of just going through this, it may be possible that some tissue is lost that would otherwise be functional and healthy. Furthermore, there can be secondary effects related to the procedure. If we're passing through tissue, or sort of navigating around tissue in order to reach a treatment target, all of those can cause damage, can cause potential opportunities for intraoperative events. And then furthermore, while technically separate from postoperative cognitive decline, many of these patients may also be having additional adjunctive treatment procedures that can also affect cognitive function. Working with a brain tumor population, it's not uncommon that they'll receive radiation therapy, chemotherapy. You can even have intraoperative radiation therapy. And realistically, while those theoretically are separate from postoperative cognitive decline, because they are not directly a part of the operation, in terms of when you're actually working with a patient, it doesn't matter whether it was cognitive decline related to this factor or that factor. It is still affecting them in their day-to-day, and our goal is still to try to prevent those as best as we can. Um, so again, both sort of direct surgical processes as well as some indirect processes can go on to contribute to some of this post-operative cognitive decline overall. And so, importantly, in being able to understand more about this is understanding what are some of the risk factors that contribute here. These include things like patient-related factors, surgery-related factors, and anesthesia-related factors. We'll start with patient-related factors. So these are things like the patient's age, education level, emotional health, comorbidities, all can sort of be contributory factors to the likelihood of developing POCD. With advancing age, there are normative degenerative changes within sort of the brain tissue overall. And these predispose older adults to experience postoperative cognitive decline and experience for it for sort of longer periods. Odds ratios for those over the age of 85 are between 2 and 3 times more likely to experience complications after surgery, just purely based on age. Furthermore, and sort of consistent with our understanding of cognitive reserve overall, level of education, particularly education levels sort of greater than high school results in sort of a lower incidence of POCD as compared to those with lower educational attainment. This has not actually explicitly been done in this literature. However, I would anticipate that similar to our understanding of the impact of education and sort of cognitive reserve broadly, the quality of education likely will have similar impacts here as we see in other literature, that simply looking at the number of years of education does not really tell the whole story for sort of level of cognitive reserve. This is really particularly important when we're thinking about an older adult population. We're considering sort of diversity factors, access and opportunity to quality education, as many of our older generations had even further exacerbated inequalities in educational opportunities above and beyond even those that sort of exist today. And so, really thinking about understanding and again, researching what this is sort of true in this population as well. However, I assume this would sort of mirror some of what we see elsewhere. Similarly, all of these can have downstream effects on things like social support, financial resources, access to quality medical care, which all can sort of similarly affect outcomes in this population. Additional preoperative risk factors include things like presence of depression, pre-existing cognitive dysfunction, as well as medical comorbidities. When thinking about medical comorbidities broadly, anything affecting the cardiovascular system, your cerebrovascular system, does tend to connote some additional risk during a surgical procedure, and some additional risk for POCD after the procedure. So this includes factors like stroke history, high blood pressure, diabetes, those sort of things all, again, increase your likelihood of experiencing postoperative cognitive decline. Interestingly, for comorbidities, depression is one that is fairly strong odds ratio greater than 10 in certain studies, and is actually one of the stronger predictors of postoperative cognitive decline. Some of these factors do vary, though, based on the type of procedure that an individual is undergoing. And so, again, we need just continued research to tease out some of the nuance that does go for this, and allows us to both make more individualized sort of assessment plans, treatment plans for patients who are undergoing surgery. In addition to these factors, things like general frailty increases subsequent risk of both postoperative delirium and cognitive decline. delirium in and of itself is also a notable risk factor for POCD with sort of long-term cognitive change demonstrating an up to 40% increase in rate of progression. So going to 40, essentially the progression increasing by 40% in older adults above the age of 70 who did experience delirium as compared to those who didn't. Um, Research has also begun to look at other factors, things like genetic risk factors. Unsurprisingly, ApoE4 has been looked at, and it has been found to have an increased likelihood of POCD. There also have been a handful of studies looking at biomarkers postoperatively, and while there have been some factors found to be associated with later persistent POCD, results at this point are still relatively mixed. They looked at things like NFL, A beta 42, total tau, things like that. Thus far, there isn't a ton of research in the area, and for much of the research, there's a lot of variability on what biomarkers they're testing and when they're testing them. And so there's a lot of variability in how those particular markers and when they're tested correspond to sort of persistent cognitive decline post-operatively. And so, I think this is an area that will continue to grow as we just have increased clinical availability of biomarkers, but does provide sort of a new way of using some of that to help us understand clinical risk for something outside of, again, some of the other ways we might more traditionally use it. In addition to some of these patient factors, there's surgery and anesthesia related factors. So the risk of POCD generally increases based on the complexity of surgery. In part, this can be related to release of endotoxins and cerebral emboli. As mentioned earlier, neuroinflammation is one of the suspected mechanisms, and endotoxin helps stimulate the release of inflammatory markers and can be partially responsible for sort of systemic inflammatory response. Additional sort of cerebral consequences, embolism, hypoperfusion, obviously all cause some increased risk for later cognitive decline. Anesthesia in general has been found to be associated with some degree of cognitive change in older adults, although studies at times can be a little mixed, although many of them are finding at least some degree of change, although there's, again, a little bit of complexity as to sort of all the interacting factors. This 2019 study by Sprung looked at older adult population, a sample of over 1,800 patients, and they found that global declines were related to both global anesthesia as well as regional anesthesia, although there were some more selective declines in memory only in general anesthesia. Studies have also found that some of the patient factors, such as lower educational attainment, can make someone more likely to be susceptible to cognitive change after anesthesia. Although, again, there is a little bit of mixed results here that I think we have to kind of further tease out as to, are there specific agents that are more likely? Are there specific patient factors so that we can understand all of these sort of intersecting, interacting factors that, again, make the particular patient more likely to experience postoperative cognitive decline. Okay, so I've told you about postoperative cognitive decline in general, and so now I want to focus in a little bit more on some unique aspects of neurosurgical populations that we might be more likely to see in sort of day-to-day practice. I chose three of them. I chose the three that are ones that I see more in my clinical practice, and again are ones that I think neuropsychologists just tend to um, more regularly assess. I do think, neurosurgery overall can be broad. And so I do think we need to continue to extend this out and understand how this mirrors for other neurosurgical populations, but we'll kind of focus on these for now. So I'm going to start with deep brain stimulation, DBS. DBS obviously can be done for a number of conditions, so psychiatric conditions, epilepsy, etc. I will really be focusing on this for movement disorders, so PD and ET, just because that is the where the bulk of the research is, particularly this. And again, when looking at all of this, the amount of research in this area really could be bolstered more. And so kind of going for those with higher base rates are allows us to at least dig into the literature a little bit more. Something that is a little bit unique about DBS patients as it relates to sort of postoperative cognitive decline is that these are patients that are often selected on their appropriateness for surgery. So, most of these patients, all of these patients are going to go through pre-surgical evaluations to try to minimize the likelihood of negative outcomes. So there might be a slight sort of selection bias in who ends up sort of making it through this process and does actually go through with the DBS procedure overall. With that said, I'm going to talk through sort of three different kind of clinical cutoffs that have been used in the DBS literature, and those are for different age groups. So if we're thinking about age groupings of those above and under 75, those above and under age 70, and those above and under age 65. I will say I did not find any studies related to cognitive outcomes on patients who received DBS over the age of 80. Anecdotally, this might just be a fairly low sort of base rate group overall. We have a database here of 450, 500 or so DBS patients that have all received testing as a part of their pre-surgical evaluation. And we had only a handful that were above 80, and we didn't have any above 85. Actually, the first one I evaluated them a couple weeks ago, that was above 85 and is moving towards DBS. It's the first one that's going to be done in our center. But again, this is just a population that we have less data on because it's not one that we've done it as much on. And with this sort of growing population, this growing need, we need to have this data. We need to have understanding of sort of the unique, potential factors that might be true for this older population. So regardless, starting with the sort of oldest age group, when using the age of 75 as cutoff, patients receiving DBS across, several studies, it was found that older patients tended to receive relatively similar improvements related to DBS. So treatment outcomes were pretty similar. There was no significant negative cognitive change, no significant increase in 90-day complication rates, infections, CVAs, seizures, readmission rates, or hemorrhages. One study did find that while the prevalence of hemorrhage was not worse, the severity of those hemorrhages was worse. And another study did find a trend toward the older population having an increased rate of hemorrhage. This isn't unexpected. This is something that we know as sort of atrophy in the brain happens, and then we sort of extend and stretch various veins. Hemorrhage just unfortunately becomes sort of more likely as we age in general. In addition to this, the older group also showed more common sort of transient post-operative AMS. They were more likely to have longer hospital stays and have some other more mild symptoms like greater urinary retention. What I will say is that unfortunately for these studies and a lot of these studies, they are using relatively gross measures of cognitive ability. So things like, the cognitive section of the UPDRS, which if anyone's familiar with is very insensitive, and things like MMSE. And so, more comprehensive neurocognitive testing would be able to better sort of ascertain whether these patients are experiencing any more nuanced changes on a more comprehensive battery. Results across the two other age ranges are relatively similar. Some studies reported that older groups had some increased negative outcomes, things like more frequent falls, need some more extensive post-surgical care, and a couple studies also noted some reduced clinical benefit. There was one study from 2016 that did actually look at, this was at the cutoff of 65 over under, and cognition was significantly worse on things like Wisconsin's Troop, free and cued selective reminding test, and verbal fluency, all after ST and DBS in sort of this older adult population. Also, a 2013 study with that same sort of 65 cutoff showed improved symptoms, mood symptoms in a younger population that wasn't mirrored in the older adult population. So while there wasn't worsening in mood, the same sort of mood benefits that the younger population received after surgery were again didn't follow in the older population. Some studies also looking more broadly at the adult population without age cutoffs have found some increased risk of neuropsychiatric symptoms, so things like hallucinations in older adults, although that's not consistent. And in total, when looking at DBS literature as it relates to older adults, there just kind of broadly is a suggestion of, some increased complications, although those are generally not severe, maybe some mildly worse clinical benefit. But at least at present, there's no consistent evidence of greater cognitive risk. And so again, overall, again, some caveats that, in this older adult population, there might be some increased complications, but we're not seeing really significant negative complications that would make us think, okay, this isn't something we can explore further with these patients. So next, I want to talk about epilepsy surgery in older adults. I will say the epilepsy population being considered for surgery tends to just be younger. And so much of this literature uses 50 as the age cutoff for younger and older adults. If you are like me and you're geriatric focused, 50 is not an older adult. Like a 65-year-old is barely an older adult for me. So this is, again, a fairly young older adult, but it is what's currently available in the literature. I think this is probably related to a lower rate of just surgical candidates later in life. We know that epilepsy is prevalent in older adults and that older adults commonly experience conditions that increase their likelihood of having a seizure. But I think it is probably less likely that we see older adults that are good surgical candidates and are interested in surgery that haven't already been through it by the time they reach later life. And so again, we have a little bit more limited data in terms of really reaching that sort of latter end of the age range. As compared to the DBS literature, the epilepsy data is a little bit less favorable overall in terms of outcomes. Across several studies, most featuring patients with temporal lobe epilepsy, older cohorts were noted to have some, increased declines in cognitive ability, particularly for things like verbal memory and naming. However, at least one study did find that underlying pathology may be an important consideration. In that particular study, what they saw was the patients with hippocampal sclerosis did not show this same pattern. That makes sense just based on what we know about temporal lobe epilepsy. If you have hippocampal sclerosis, you resect that location, you're not expected to see cognitive change because that tissue at that point isn't functional. And so it's not necessarily surprising. So again, part of this might be understanding it again for which patients in particular there might be an increased risk for older adults. Older adults also tend to have an increased complication rate as compared to younger control groups. And several studies found that benefits may have been better for younger populations. The caveat to that is, despite there sometimes being slightly lower overall seizure control, still these patients demonstrated consistent benefit from procedures, demonstrated things like improvements in quality of life. So while older age may connote some increased risk as compared to the younger populations, as we do with all of these, a risk sort of benefit analysis may still end up favoring surgery if it can result in increased seizure control for an elderly population. And then finally, I'm going to talk a little bit about neuro-oncology and brain tumors. In thinking about surgeries, something that's important to consider is that, as compared to, the more elective nature of something like DBS, you know, surgeries targeting, these tumors often can be more emergent in nature. And so, the possibility of some effect on cognition is less likely to be something that would stall the surgery, but would be more. It could still be helpful for us to know for both treatment, both prior to and sort of after surgery. Research in this population has mostly been done with gliomas. Gliomas are the most common intracranial primary malignant tumor. They have an increased incidence in the elderly, and importantly, cognition has been found to be an independent prognostic factor for these patients. You know, prior studies have found some worse outcomes for older populations related to changes in language, tension, behavioral dysfunction. In gliomas, the elderly population, so those over the age of 65, show an increased rate of major decline in cognitive ability, although there are additional factors to consider, like tumor volume and sort of volume of edema. Older adults also have a higher risk of frailty, increased post-operative complications, anemia, infection, kidney injury, infarction, mortality. Some studies show that the strongest predictor of favorable outcome for this one was looking at glioblastoma in particular was age. But importantly, aggressive treatments have been still found to lead to improvements even in those over the age of 80. So again, in sort of this older adult population, when we're looking at neuro-oncology and we're looking at brain tumors, there does appear to be some increased risk for both complications and cognitive decline. But at least as it relates to gliomas and sort of our current data as it stands. And so, overall, again, what we are seeing is that, as we might expect, dependent on the type of procedure, the potential risk can vary, potential complications can vary. And as I've said throughout all of this, we really need more research in this area. So this is something that you are passionate about. This is something that I think will be a growing area for us to sort of look into. And so finally, very quickly, I want to talk about some clinical recommendations based on this. Um, for this data, I think it's important to consider, how we can impact these patients, how we can impact our healthcare system, and what we can do as neuropsychologists. And I'll take this from kind of two perspectives, both an assessment perspective and an intervention perspective. I am someone who is more assessment based, and so I think there's a lot of opportunity here for us to be able to assess patients, both non-surgical, non-neurosurgical and neurosurgical, preoperatively. We know pre-op cognitive ability is one of the most common predictors of postoperative cognitive decline. And so I think as neuropsychologists, we really need to continue to advocate for roles within treatment teams, particularly within treatment teams that maybe we haven't more traditionally served on. Something like a DBS team is something that's fairly common, but we less commonly see us in other treatment teams. And so I think as neuropsychologists, we need to both establish that we can have a benefit to those, and then also put ourselves out there to actually make those differences in sort of the clinical work that we do. In doing this, I think one of the things we really need to figure out is sort of protocols and scheduling of assessments, so that we can best sort of assist patients. Um, at a minimum, I think a pre and post-op assessment is necessary. However, I think more likely what we'll see is repeated post-operative assessments. There is some value in providing a post-operative assessment reasonably close to the surgical procedure, because that allows us to provide an opportunity to identify patients at greater risk for post-operative cognitive decline, which can then sort of subsequently be addressed through treatment strategies. Furthermore, kind of depending on patient population, repeated assessments out, either as a guide for treatment planning or as a possible indicator of recurrence or treatment responsivity in a neuro-onc population. However, outside of just evaluations, I think neuropsychologists can provide a lot of value in treatment services, both before and after surgery. And so I think 2 talks from now, someone's going to do a whole lecture on this. So I'd encourage you all to attend. I think this is something that's a very sort of exciting area for us. But we have opportunity for both prehab and rehab. So prehab is something that aims to really improve baseline functioning, reserves for surgery to facilitate better recovery, reduce post-operative complications and cognitive declines. There's in various sort of groups looking at programs for this, both purely cognitively based ones, but also seen ones involving things like neuromodulation or also general sort of physical health programs. So things like integrating in exercise as well. Neuropsychologists can also have a role in that sort of post-surgical cognitive rehab, help improve recovery, assist in functional abilities, and, help patients with compensatory strategies. And I also think, we're sort of uniquely qualified to help both assess for certain known risk factors like depression. And then also I think we do well at providing psychoeducation to sort of help patients to, again, hopefully prevent the prevalence with which some of this postoperative cognitive decline occurs. So these are just references. I'm just going to wrap up really quickly, even though I've not been great on time. Just as a kind of broad summary, we have this increasing age population. We have a population that is going to have a number of conditions that require neurosurgical intervention. We need increasing expertise in geriatric neurosurgery. We're obviously not neurosurgeons, but we have a role to play. We have a role in assessment. We have a role in intervention. And I think this is sort of a very exciting area that we can explore both clinically and research-wise moving forward. With that, if there's questions, I'm happy to take them.
Thank you so much, Dr. Isaac. Can you hear and see me okay?
Mm-hmm.
Okay, great. Well, that was a fantastic lecture. You touched on so many important topics and something. I am a pediatric person, so when you're talking about how younger children are just not, younger adults, and hearing about that from the geriatric perspective was really insightful. So I appreciated that comment. And then I think it's also important too how you highlighted the difference in terms of the quality of education that the populations that you're seeing have received and how that varies. Is we're not just looking at the numbers in terms of years, but what did that quality look like? So for your fantastic lecture, we have several questions that came in. I know we're short on time, but do you have a minute to answer a couple of those?
Sure.
Okay. So let's see. You touched on this, but I wonder if you can provide a little bit more specific based on what this question is asking, maybe. What recommendations do you typically make for older adult neurosurgical candidates?
Yeah, I think broadly a lot of the things that we would be considering in general for good neurologic health is going to be good for a neurosurgical candidate. So things like managing cardiovascular risk factors, diet, exercise, as is appropriate given, again, kind of depends a little bit on their condition. Um, managing any factors that we know increase risk. So, if you assess a patient, they have increased rates of depression, then, connecting them to resources, getting them into treatment to, again, lower that overall level, and again, decreasing their risk for post-operative cognitive decline. And so really, I think on the front end, our goal is really to be able to assess what of these factors that the patient does have and intervene in the ways that we have. Also, when you're serving on a neurosurgical team, I talked about this from kind of our perspective, but you are a team. And so I'd also encourage you, if you are noticing things about a patient, if you're noticing things that are concerning, is to also bring that into the neurosurgical team, is to collaborate again as a team to try to make sure that patients get the best outcome possible, because that is when teams are sort of best functioning, and that's when we can best serve our patients. So again, being someone who is observant, digging into the literature a little bit to know what to look for. You don't always have to be the one that can fix it, but even sort of raising some flags for the team can sometimes help them do it, and maybe it gets addressed by someone who is more appropriate, who's sort of more in their area of competence.
For sure. And you mentioned depression, and another question we had that came in terms of providing that collaborative, holistic, and comprehensive approach to these patients. This question is asking, so since depression is the strongest risk factor for POCD, are interventions, either pharmacological or psychotherapy, protective?
So I want to hesitate because I don't know that I've actually seen it exactly said in that way or research done to say that it's protective. We know that increased depression is related to post-operative cognitive decline. Theoretically, that could be due to multiple reasons. If you think of some of the comorbidities that might make someone more likely to have depression, maybe there's some way. But again, like theoretically, yes, if we are able to sort of decrease that overall level, we would be preventative in nature. I don't know that if someone is at sort of baseline, not clinical levels of depression, that again, doing therapy, things like that would necessarily be helpful. But again, I would expect that if we can get them lower overall depression levels will lead to more positive outcomes. Again, we haven't quite done that research in that way though.
Another question, does a history of delirium increase the risk of POCD, or is it delirium resulting during the current surgery that increases the risk?
Just read that one
Yeah,
more
I was
time
going
for
to
me.
say, I can read that again. Um, so, does a history of delirium increase the risk of POCD, or is it delirium that's happening during the current surgery that increases the risk of the POCD?
Okay, so basically asking, yeah, so the history of delirium in research is related to that particular intraoperative or that operative sort of experience. So it is related to that particular um, uh, surgery. I think it is an interesting question is if any delirium at all would potentially increase your risk. I do think there are some particular mechanisms that happen when you're going through a state of delirium that would potentially put you at risk at any time throughout If you have delirium at any time throughout your life, it also suggests sort of like a lower delirium threshold, which again, I think also connotes some additional risk. But at least in the literature, what is looked at is delirium related to that particular surgical procedure and not delirium at any time throughout your life.
So we will do one more question here. So since there are known patient risk factors for POCD, is there a predictive model used to clinically decide whether an older patient should undergo DBS?
So I don't know of any currently clinically used predictive models. I do think that is exactly where many of these things are going to go. And I think as we continue uh, as a world to have increasing data availability, we need to find increasing ways to use that data to improve outcomes. So yes, I think at some point there will be clinically available predictive models to calculate some of this. I'm actually working with someone in our geriatrics department. It's not related to this. He's trying to do it for rates of ARIA. But again, there is that work being done. I'm sure it is also being done on DBS. I don't know of any of it being used clinically at this point, though.
Well, those are our questions for today, and thank you for staying over time with us as well. And we're so appreciative of you sharing your expertise in this area. Clearly, a lot of good work happening, but a lot of good work that needs to happen in the future too. Thank you again for your time. And to the rest of our uh, guests that have joined us today, please join us on October 7th for the next lecture on pre-surgical epilepsy evaluations, including cross-cultural evaluations. Thank you, Dr. Isaac, and thank you, everyone else.